Hi everyone, this is M.B.B.S nerd and I'll be talking about T cell lymphoma. So let's begin. Now T cell lymphoma, as the name suggests, arise from T cells but have certain characteristics. And we have to talk about these characteristics. Like there is diffuse effacement of lymph nodes in all of these lymphomas, T cell lymphomas, consisting of pleomorphic malignant T cells. Also, the T cells are surrounded by eosinophils, macrophages due to secretion of cytokines by T cells. Basically, these neoplastic T cells, what they try to do is that they try to create a harmonious environment around them, and for the creating the harmonious environment they secrete cytokines or growth factors that you can say keep these eosinophils or macrophages around them. They are surrounded by these eosinophils and macrophages. And also the IHC markers are generally positive for CD2, CD3 and CD5, which are normally present in T cells. Also the clinical features are generalized lymphadenopathy, pruritus, fever and weight loss. Now pruritus is due to the increased eosinophilia and the mediators released by the eosinophils, as just like I told you that the T cells, they stimulate eosinophils by releasing cytokines. Now let's talk about anaplastic large cell lymphoma, which is a type of T cell lymphoma. Now it is a very rare lymphoma presenting in children or young adults and has a good prognosis. Also, if I talk about the pathogenesis, then there is rearrangement in the genes. ALK gene, which is present on chromosome 2p23. Here P stands for the short arm of the chromosome, and the chromosome number 2, the short arm of the chromosome number 22, and this is the coding region basically. So what happens is that this gene ALK is translocated to the NPM gene, which is present on chromosome 5, and this creates a chimeric gene, you can say a hybrid gene is created, like this ALK or NPM is alongside, and they constitutively produce a chimeric protein which activates RAS and the JAK-STAT signaling pathways, which is the part of many growth factors and signaling receptors, signaling of many receptors. So this flowchart sums up the pathogenesis very beautifully of anaplastic large cell lymphoma. And if I talk about the pathogenesis, then if tumors are ALK positive and ALK negative, basically ALK negative are those in which translocations have not taken place and they are very rare, and ALK positive is what we see most commonly. So what happens is that this leads to JAK-STAT3 activation, and in ALK negative tumors there are some other translocations, some sporadic fusions, and we also see mutations in the JAK-STAT pathway itself. There is no chimeric protein production. So this ALK negative protein or the ALK negative tumors have the worst prognosis. Now, if I talk about the JAK-STAT pathway, then the JAK domain is activated by many lots of things, and if it is here in this case, it is activated by a chimeric protein, and this leads to the autophosphorylation of the STAT3 domain of the JAK-STAT pathway, and this leads to the suppression of P53. This red line here shows suppression. P53 is a tumor suppressor gene, which leads to the neoplastic transformation. Also, there is increased stimulation of BCL2, which is an anti-apoptotic protein, and the increased stimulation of VEGF or the vascular endothelial growth factor, which leads to the increased survival and proliferation of the tumor cells, promoting its neoplastic transformation. If I talk about the clinical features, then there is fever, generalized lymphadenopathy. Extranodal presentation is very common, especially in the soft tissues. We can see these lumps or bumps in the tissues, tumor-like lumps and bumps in the tissues, especially in the soft tissues in the neck, extremities, and trunk in the subcutaneous region. Also, spleen and the bone marrow is involved, and tumor cells have a tendency to cluster around venules and lymphoid sinuses when they involve the lymph nodes. So, why the subcutaneous region? These two question marks are the questions I want to answer. So, you see, as you will, if you think and ponder that in the subcutaneous region there is superficial lymphatics, and T cells are those cells which commonly encounter the antigen, the which are present on our skin. So when these antigens, they are processed by the Langerhans cells or the antigen presenting cells of the skin, and they present it to the T cells. And T cells, as you know, they are frequently you know uh, checking the antigens which are, or surveilling the antigens which are being given to our body. B cells are not commonly involved in antigen presentation. It is very rare that a B cell takes or processes an antigen. They also do, but it is not that common. Most commonly T cells only. That is why these T cells have a they have a tendency to home, or whenever they form a neoplastic proliferation occurs, then they home in these subcutaneous region, or we see these lumps or bumps. because this subcutaneous regions is having lymphatics or the lymph nodes, and if the lymph nodes are elevated, so we see the bumps in the subcutaneous region. Also, the tumor cell cluster around the venules and the lymphoid sinuses. And why so? Because venules and lymphoid sinuses again are those places in the lymph nodes which are commonly involved in antigen presentation. That is why tumor cells have a tendency or a characteristic to cluster around these sinuses, because normally when they were not neoplastic they were present there, but now since they have been they have become neoplastic. But you know, bad habits die hard, just like it has been told. So it has a bad habit to cluster around the lymphoid sinuses and venules. Also, if I talk about the morphology of the cells, then the cells show a cohesive pattern of growth. They are very close to each other. As you can see that these all cells, these neoplastic T cells, they're very close to each other. They're not far apart. And we see that these cells have anaplasia. It means you will not be able to make out their differentiation. As you can see that clearly, if I tell anybody, any medical student, that this is not a lymphoma, they will not be able to tell that these cells are T cells or were T cells, because they are not showing the characteristics of T cells. Neither they are having a large nucleus, neither they are having the size. The size is also varying. Some cells are small, some cells are very very large. Even the nucleus is also varying. Some nucleuses, some are multi-lobed, some are having one or two nucleuses, some are having three nucleuses, some are having one nucleus. So there is huge amount of pleomorphism, and there is no differentiation also. That is why they have anaplasia and show multiple pleomorphic nuclei and nucleoli. Also, there is a perinuclear eosinophilic clearing, which is also called Golgi zone, and cells present with horseshoe kidney or embryo-shaped nuclei, and also have a voluminous cytoplasm. That is why it has been called anaplastic large cell lymphoma, because these cells are showing anaplasia and they are also very large. So these cells, these characteristic T cells of anaplastic large cell lymphoma are also called hallmark cells. As you can see here, that these T cells have this kidney-shaped nuclei. Here, if I point this out, then this is also shaped like a kidney, and this is shaped like an embryo. So these are the shapes which are present here. Also, this this T cell lymphoma has a characteristic to infiltrate these lymphoid sinuses. As you can see here, these sinuses, they have been infiltrated by these neoplastic T cells. And if I go, and they also have increased mitotic activity. If I go to my previous question, that why there was diffuse effacement of the lymph nodes, so you can see here that this part here, this which is labeled here, these sinuses, these marginal sinuses, or you can say this part here, this is the subcapsular sinuses. These afferent lymphatic vessels, they drain antigens to these subcapsular sinuses, and these subcapsular sinuses are the places, or the sinuses are the places where antigen presentation is frequently going on by the antigen presenting cells to the T cells. So these T cells are frequently clustered around here, and they are also present in the paracortical region. Now what happens is that since these T cells have a tendency to cluster around these venules or the sinuses, so whenever a new plastic proliferation occurs, they surround, you can say they have a surrounding kind of a growth around the follicle, and this is what causes the diffuse effacement of the lymphoid follicle. That is why we see that this line, that is why this is the explanation of the line, that why there is diffuse effacement of the lymph nodes consisting of pleomorphic malignant T cells. And if I talk about the immunohistochemistry marker, then obviously CD3, CD5 is positive, but a characteristic immunohistochemistry marker is the CD30, which is positive in this case, and which is a sure shot diagnosis for anaplastic large cell lymphoma. So I talked about anaplastic large cell lymphoma today. So I'm ending my video. If you like this video, give a thumbs up, comment on the comment section, please subscribe. I will see you.